Can we reliably identify vulnerable plaque? For decades, we've been wondering, in real time maybe, and in vivo. We're talking with the worldwide leader for a rather interesting trial. This is Ron Waksman, who is the Director of Cardiovascular Research and Advanced Education at the MedStar Heart Institute in DC, and you're the lead investigator for the 9,000-patient LRP study, lipid-rich plaque study to evaluate prediction of heart attack. Tell me a little bit about the study, then we'll talk about the technology itself.
So thank you. As you mentioned, there is an unmet need. We do know that patients still had a sudden death and they tend to die from rupture plaque. And for over 2 decades, we've been trying to identify in vivo a potential surrogate for a vulnerable plaque. And I think now we have a good indication and a good signal that we have this technology using the infrared, which is a near spectroscopy that enable us to detect a lipid content within the plaque that it's not necessarily stenotic. These are plaques that you wouldn't suspect to them in a regular angiogram, but when you do the IVUS and your infraredics, you can detect a quantity of lipid within the plaque that we believe that could tell us or be predictable to an event. So that actually has to be proven, obviously, and in order to prove that, we are embarked on a study which is called the LRP Study. And as you mentioned, we are targeting up to 9,000 patients into the study. But the goal is to look at 2 aspects. One is the vulnerable plaque, but also, not less important, is the vulnerable patient.
Yes. There was a couple of papers in, I think, Circ a few years ago that really started to distinguish there is a vulnerable patient as well as vulnerable plaque.
Correct. So let's assume that we do find in those patients' coronary arteries amount of lipid within the plaque, which would be a threshold that would be correlate highly with any event in the patient. Not necessarily within the same plaque, but those patients who had the high LCBI, which we call the lipid content within the plaque, would be also patients that would have more heart attacks, more sudden death, and more revascularization and unstable angina over time. That speaks for the vulnerable patient. Now, more specifically, we would like to know that indeed are those plaques that we see them that high content of lipid, they are the one that are the target for those, or the causality for those events. If that's the case, then we can move to the other part of the study, which to try treatment strategies to passivate that plaque and to prevent those events. So first stage, we have to see that our hypothesis is right, that indeed those lipid content within the plaque are predictors for events.
With 9,000 patients, that's a lot of people. Who are you looking for in order to enroll into this trial?
That's an excellent question. So obviously, the patient population would be patient that comes to the cath lab anyway. We are taking patients that are enriched population, which means that they come in already with acute coronary syndrome for an angioplasty or for an angiogram, but we believe that those patients are the highest risk to begin with. And what we are doing is, regardless whether you treat the lesion or not treat the lesion, we are assessing as many vessels as we can to do a pullback of a run for IVUS and the infraredics technology to get enough information what's happening with the rest of the arteries other than the one that is being treated or the culprit for the symptoms. So this is our patient population for this specific study.
Now here at TCT, there were a number of papers presented relating to this technology. Spectrum Health's Ryan Mader had one on identification of vulnerable patients by intracoronary near-infrared spectroscopy. Can you just tell me what he did in that study?
Yes, so actually there are several papers over the last 2 years that consistent with those observations that patients who present with STEMI, if you look at the LCBI content, at the content of the lipid in the area of the STEMI, the plaque that was contributing, it's going to be very high, in contrast to the adjacent areas in the same vessel. Now, that was one observation. The other observation was that Ryan Mader looked on patients who were survivors of CPR and brought to the cath lab, and he found that in all of them, there was also a high lipid content in the plaques that were related to this CPR, which was the main event. Further, there are some, again, these are all anecdotal, that's why we have to do the large cases, some work that comes from Erling from Sweden on observations of those lipid content within the plaques that were not treated and were not stenosed, and then a few months later turned to present with unstable angina, ACS, and narrowing that was required to stent. So we're getting more and more signals that indeed this technology has the ability, number one, it's correlated very nicely with the event. Number two, we're starting to see signals that are the poster child of the study, that they would basically tell us if you find this high lipid content, you should expect to have within the next year an event. And our study actually looking 9,000 patients, but it doesn't have to enroll 9,000 patients. We actually, and it's a very interesting statistical and novel concept of study design, we're looking at the number of events. When we reach to that number of events, let's say 150 events in totality of the entire patients that are being enrolled, we would be able to say, okay, now that we have 150 events, we can look on those IVUS and infrared study that we've done, and we see if this is correlated. So in this study, we store all the patients that are being having a study, so we'll be able to correlate this to the event and to look at their LCBI.
Now, if in the lipid-rich plaque study you detect an LRP very early on, do you then put them on high-dose statins to help dry them out? Do you just observe them? What are you going to do?
So that may be stage 2. In stage 1, the investigators agreed to be blinded to the finding.
Okay.
So they don't know, and it's only the core lab that knows, so they cannot impact treatment. They can do, the only thing that they can know is the plaque that they're actually treating, right, which is the putting the stents. But they don't know what is happening in the other vessels or even in the adjacent segments of the same vessel that have been treating. So I think that's actually the nice thing. They don't necessarily have to treat it. We tell them, do whatever you believe is the good for the patient, and we'll find out. And plus, we don't know if high dose of statin is going to make the difference. I mean, maybe they need, but with the emerge of biodegradable scaffolds, I think there is more interest in the fact that you may be able to passivate those plaques with also a mechanical treatment. And because biodegradable scaffolds are disappearing, we're not going to have to commit the patient forever for a stent. So technology is advancing for potential therapeutic options if the hypothesis is right. So stage 1, let's find if we can indeed detect vulnerable plaque in vulnerable patient. Right. Stage 2, and it's all going to be within the 9,000 patients. That's why we have such a large patient population. Stage 2 would be once we identify that this is something that needs to be treated, we're going to look at different treatment modalities. One would be pharmacotherapy, one would be maybe scaffolds. We have a wide variety of options that we can choose and treat.
Well, it's an exciting time in cardiology and has been for a few years now, but this really sounds like a fun study to do, and it could be really interesting to see how this turns out.
Indeed, and it's actually what's resurrecting. You know, the vulnerable plaque concept has been floating for more than a decade, yes, and it has ups and downs. But I think for the first time after many years, there is a resurrection of the enthusiasm of investigators, operators, because those cases make sense and they are accumulating. And that's why I think we put everything in a scientific way to address this question, and people getting excited about it.
Yeah, absolutely. And there's a variety of exciting things that have come out of the TCT meeting, so please look around for our coverage in CardioSource World News, where I'm Executive Editor Rick McGuire.